What you learned so far applies to all patients who have dilated cardiomyopathy. Now we're going to look at some specific forms. What is inside this chapter? We'll be looking at hypertensive cardiomyopathy, ischemic cardiomyopathy, stress-induced, peripartal, HIV-induced cardiomyopathy, non-compaction syndrome, Chagas cardiomyopathy, and finally at arrhythmias and tachycardia-induced cardiomyopathies. Strictly speaking, this would not be a dilated cardiomyopathy because the ventricle is not dilated. Still, left ventricular function is poor and it is a primary myocardial disease. This is a patient who was highly symptomatic actually, who had long-standing hypertensive heart disease and his function started to deteriorate. Now, such patients, of course, do not develop such large ventricles because the ventricle is stiff because of the hypertrophy, and you will very rarely see such rounded spherical ventricles as in the classic form of dilated cardiomyopathy, where the wall is often very, very thin. Nevertheless, these patients can be very symptomatic because remember, you always tend to overestimate left ventricular function in the setting of a small ventricle. Remember, systolic function also depends on afterload, and blood pressure increases afterload. This example shows a patient who came into the emergency ward because he had pulmonary edema. A patient who was hypertensive, you see that there is left ventricular hypertrophy, and with acute rise in systolic blood pressure, his left ventricular function deteriorated further. And this led to, of course, pulmonary edema. So remember, we can have both acute and chronic effects of hypertensive heart disease. And we're going to have a specific topic that's going to deal only with hypertensive heart disease. But at this point, it's important to realize that we probably underestimate left ventricular function in these patients and that we often need other imaging modalities to detect that they truly have systolic dysfunction. For example, speckle tracking and deformation imaging. In summary, you will find hypertensive cardiomyopathy in patients who have long-standing chronic hypertensive heart disease. You will always find hypertrophy. The ventricles are smaller. You will overestimate left ventricular function. Look for subclinical dysfunction in these patients. And be aware that patients with hypertensive heart disease also have a higher probability of having coronary artery disease as well. This brings us directly to ischemic cardiomyopathy, which is actually the most frequent cause of cardiomyopathy because many patients have coronary artery disease. Now, the reason these patients develop heart failure is clear because we have a remodeled ventricle. In other words, we then have a diffuse left ventricular dysfunction, and it usually occurs in those patients who have large infarcts. Here's an example of a patient who had a left main stem occlusion, one of the few patients I actually have in my database because patients usually do not survive a left main occlusion. And you can see that the entire left ventricle is diffusely reduced and it looks very much like dilated cardiomyopathy. Why do we need to know if a patient has ischemic cardiomyopathy? Because these patients probably have a worse prognosis than those with other causes of cardiomyopathy. Some of the facts: we see it more frequently in anterior versus posterior infarcts, if patients have multiple infarcts, and if additional valvular heart disease is present. For example, a patient had an infarct and then has additional aortic stenosis, then the ventricle has to pump against a higher burden, higher afterload. And that, of course, leads to left ventricular dysfunction, which progresses more quickly than if you would not have valvular heart disease. The same is true for example, mitral regurgitation. And furthermore, we see ischemic cardiomyopathy more frequently in the elderly population versus dilated cardiomyopathy, where even children or young individuals can have the disease. The next important form of cardiomyopathy I would like to talk about is the so-called stress-induced cardiomyopathy, or Takotsubo syndrome, or broken heart syndrome as it is also called. It's a form of cardiomyopathy which has a very typical feature where we have dilatation of the apex and sometimes hypercontractility at the base. So it looks like an aneurysm actually. We also call it apical ballooning. Now, why do you get stress-induced cardiomyopathy? Because you have very high emotional stress. Here's a patient who had very high emotional stress. You know why? Because her water pipe broke. And she was so upset that she developed overt heart failure and had to be brought into our emergency room. She even developed a thrombus. But here you can see the typical features of apical ballooning. You see that there's a dilated apex, and you see that there is hypercontractility actually at the base. Sometimes this hypercontractility can be so intense that you have LVOT obstruction in addition to this apical ballooning. So the typical characteristics are you would have high emotional stress caused by high levels of catecholamines. It's more frequent in women. Maybe, or we don't really know, but possibly there is also a microspasm involved in the development of this left ventricular dysfunction. In some patients, you might also see right ventricular involvement, and the good thing about it is it's reversible. We've seen many patients with all sorts of emotional stress that has caused basically this stress cardiomyopathy. Very frequently, it's love. But remember, stress cardiomyopathy is reversible. Next on our list is peripartal cardiomyopathy, which is defined as the development of systolic dysfunction either late in pregnancy or shortly after delivery. We do not really know why patients develop this form of cardiomyopathy, but there are a number of different theories. One is that inflammatory cytokines are involved, that it is some form of myocarditis, or that there might be an immunological reaction between the mother and the child that causes left ventricular dysfunction. Now, here's an example of a patient who developed severe shortness of breath during, I think it was the 29th week of pregnancy. And frequently these symptoms are misinterpreted, as it was in this patient, because they say it's just a large belly that causes dyspnea. But then she developed overt heart failure, and we had to perform acute cesarean section, and the patient almost died. So these situations can be very, very acute, and we've got a number of different cases which we actually collected. If you go to our blog and our webpage, you will find a few very dramatic and very interesting cases as well of peripartal cardiomyopathy. But coming back to the risk factors, usually it's patients who are older than 30 years, multiparity, African descent, and multiple fetuses are the risk factors. And the mortality is somewhere in the range of 6 to 10%. And usually about 50% of patients then revert to a normal left ventricular function after birth. 50% then stay with a dilated cardiomyopathy, and as a number of patients will need acute treatment because they have acute heart failure. What are some other important risk factors? It's preeclampsia and eclampsia, as well as postpartum hypertension should also be considered, as well as maternal cocaine abuse. Here is the next form, HIV and cardiomyopathy. Now, HIV can obviously also cause cardiomyopathy because it can cause myocarditis, but the incidence is highly variable and depends where you are. In Burkina Faso, the incidence is 79% of all patients of cardiomyopathy, while in Italy, it's only 6%. This depends not only on how frequent HIV is present in the population, but also how it is treated. In other words, if patients have very intense heart treatment, then the incidence of HIV-induced cardiomyopathy is rather low. So you only have the severe, very severe cases of HIV which will develop cardiomyopathy. What is the pathomechanism? Well, we know that it's some kind of a focal myocarditis, and that frequently you will find other viruses in the biopsies as well, because the patients are immune compromised. That's where you have other viruses that are in the myocardium in addition. You have a number of different subclinical forms. Sometimes you only see mildly reduced left ventricular function. And the treatment, of course, is very important, as already mentioned. If you have intense heart treatment, then the patients do not develop this form of cardiomyopathy. Overt cardiomyopathy, as a matter of fact, is relatively rarely seen, at least in our patient population. Only about 1 to 3% have really severe heart failure. We've got another very interesting form of cardiomyopathy, and that is the non-compaction syndrome. What is the non-compaction syndrome? Well, you have to understand that during fetal development, the muscle is actually just one bundle and that there's not a cavity. And then during the fetal development, a cavity forms, but there are no coronary vessels yet to supply it. To have blood supply for the myocardium, you have a spongy appearance of the ventricle, a so-called trabeculated muscle bundle, which allows the blood to supply the myocardium. Under normal circumstances, once the coronaries form, this trabeculation vanishes to some extent. However, in some patients, there is a persistence of this trabeculation, and in this case, we often find left ventricular dysfunction as well. That's why this syndrome is called hypertrabeculation syndrome or non-compaction. Here's such an example that shows the typical features, namely a spongy appearance of the ventricle. To visualize this myocardium, it's sometimes necessary to use atypical views. In this case, we have a 4-chamber view at the base of the heart where you can see the coronary sinus. So those are the sinusoids, and this is the spongy appearance of the myocardium you'll be looking for. And of course, left ventricular function is reduced as well. Here's the same patient, now in a normal 4-chamber view, where it's more difficult to see the trabeculations. You see them here on the lateral wall, and you also see that left ventricular dysfunction is present. Now, the non-compaction syndrome can sometimes be associated with other abnormalities, such as Epstein, bicuspid valves, aorta to left ventricular tunnel, congenitally corrected transposition of the great arteries, and neuromuscular disorders. What is the etiology? We think it's a genetic disease, which is probably familiar in many instances, but you can have spontaneous mutations so that you only have one individual in a family that has a disease and not the parents, for example. And we also know that there's a number of patients who have subclinical forms. So you do not necessarily have to have left ventricular dysfunction in the setting of non-compaction syndrome. But there is a suspicion that if you have a non-compaction syndrome in a normal left ventricle, then you can still have you're at higher risk of developing overt left ventricular dysfunction at a later stage. So you have to follow these patients along. And of course, I would advise you to also do family screening. Here's another example of a little bit of a different type of hypertrabeculation syndrome. You see that there are very prominent trabecula here and recessi here and here as well. And you can see them in the inferior wall as well. Note that left ventricular function is poor, and that if you look just on the surface, it appears as if it's a normal dilated cardiomyopathy. Do we really have to know what the cause is? Yes, I think you do, because these patients are at high risk of developing sudden cardiac death. And this patient actually is a sudden cardiac death survivor. When it comes to establishing the diagnosis, 2D imaging is still the most important modality we have. And there's been a number of different attempts to set forth criteria for the diagnosis. For example, one would look at the percentage of spongy myocardium to normal myocardium. Now, honestly, I find this very difficult to do in clinical practice. But what is definitely of help is if you use contrast. Because if you use contrast, you will see the contrast as it passes in the sinusoids between the trabecula. If you don't have contrast, use color Doppler. That sometimes is also of help. And if you're not certain, you can also use magnetic resonance imaging, which gives you wonderful pictures of non-compaction syndromes. Let me now show you a patient who has non-compaction syndrome, and let me demonstrate how we investigate such a patient. So this is a patient that's presented with arrhythmias, and let's take a look at her left ventricular function, which is normal. We have normal parameters with M mode as well, and with other ways of quantifying left ventricular function. However, if we move the transducer downwards a bit, we do see that there are a lot of trabeculations here at the apex, and there's also prominent papillary muscle. We can see that also in a 4-chamber view. I'll just have to use an atypical view to show you. You can see that there are a lot of trabeculations here. And what we have here is probably a rudimentary form of a non-compaction syndrome. It's important in these patients that you really tilt the transducer in all directions so you get a good appreciation of the trabeculations. And also to follow these patients to see what the further developments are. The next form of cardiomyopathy is a form that we very rarely see in Europe. the so-called Chagas cardiomyopathy. It is caused by Trypanosoma cruzi, which not only causes heart problems, but also megaesophagus and megacolon. The vector here is a special bug, the teratomine bug, which is very common throughout Latin America and which carries the infective agent with it. The typical feature is that we have a predominance of right heart failure, and it was discovered by Carlos Chagas. Now, some of the other important features is that it causes regional left ventricular dysfunction, often very small aneurysms. So in more than half of patients will we see these aneurysms, and eventually the patients develop moderate to severe left ventricular dysfunction. Now, in Latin America, there are specific Chagas clinics, and to be honest, I do not have very much experience with this disease. But nevertheless, you need to recognize it. So look for the typical features of aneurysms and right heart predominance. More frequently than with Chagas cardiomyopathy, we're confronted with tachycardia-associated left ventricular dysfunction. Why does that occur? Well, simply because the heart is beating so quickly that the energy is depleted from the storages, and we therefore develop heart failure. Often we have associated problems, for example, ischemia. Or if a patient already has subclinical dysfunction, he might not tolerate a rather high heart rate. There are also theories that calcium channel activity is involved here in this disease process, and that oxidative stress might play a role as well. But whatever, usually we'll see patients who have rapid heart rate in atrial fibrillation, sometimes heart rates of about 140 or 150, if they persist over longer periods of time, can lead to left ventricular dysfunction. The good thing is, it's reversible. And if you wait after 3 or 4 months, the patient might again revert to completely normal left ventricular function. Here is such an example. You see on the top a patient who has a very high heart rate. Not only that, he also has mitral regurgitation. And then, after we converted the patient to sinus rhythm, and after 3 or 4 months, we repeated the echocardiogram, and you can now see that left ventricular function is completely normal. So be aware that patients with tachycardia can develop cardiomyopathy, but also be aware that in general, it's very difficult to really assess left ventricular dysfunction in patients who have high heart rates. Tachycardia is not the only form of arrhythmia which can lead to left ventricular dysfunction. If you have very many ventricular ectopic beats, you can also develop some form of cardiomyopathy, which is called arrhythmia-mediated cardiomyopathy. Here on the left-hand side, you see a patient who has poor left ventricular function. Of course, it's not very severely reduced, but it's definitely poor. And on the right-hand side, you can see that the patient has ectopic beats. Now, if you have more than approximately 17,000 ectopic beats in a 24-hour Holter monitor, you're at risk of developing such a form of cardiomyopathy. Again, be aware that it's very difficult to assess left ventricular function in patients who have, for example, very many ectopic beats, as in a bigeminus. So this is a form of cardiomyopathy you have to be aware of, and which I think is in some way underestimated with respect to its prevalence. Take a look at this example here. This is a patient who has an ectopic beat, and you see that during this ectopic beat, contraction is very obscure and very dysynchronous. In other words, it's like he's having a left bundle branch block. And if you imagine that this patient would have very many of these ectopic beats, no wonder left ventricular function starts to deteriorate after time and cardiac output is not normal. So this, I guess, is the basis of this disease entity. Good. So I hope you saw how variable cardiomyopathy can be, and that specific forms can look a little bit different and obviously need different forms of treatment.